Hello, this is Michelle from Physioactive Indonesia, bringing to you our Singapore Surgeon Insight series. Today, joining us is Professor Hee Hwan, specialist in orthopedic surgery from the Pinnacle Spine and Scoliosis Center, Singapore. How are you, Professor?
I'm fine, thank you. How are you, Michelle?
We're doing well. Professor, let's start with a brief introduction. Can you tell us a bit of your qualifications and experiences, please?
All right, I'm an orthopedic surgeon with a special interest in spine and scoliosis surgery. So I've graduated 30 years ago. It's quite a long time. And
Yes.
Subsequently specialized in the orthopedic surgery in 1996. And in 1999, I subsequently went to the United States for spine fellowship training for a year.
Okay.
And after that, I'm kind of basically a full-fledged spine specialist, basically doing most of the time spine and scoliosis work. So in a way, I've been in touch with spine for a long, long time. And I've seen lots of changes, developments happening over this 2 to 3 decades.
Okay, so what would you say has been the challenge so far, Professor?
Well, the challenge so far has been the increasing longevity of our population. So, and at the same time, it goes in tandem with the increasing degeneration of the spine and osteoporosis of the spine. So that presents a triple challenge, And maybe there's a fourth challenge. So increasing expectation of the patient. Expectation means, although they're getting older, they want to do a lot of things that they were or are used to doing.
Right.
So meeting these four challenges, I think, is sometimes we can meet it, sometimes a little bit of tall order.
Okay. Well, that's interesting. Today, we will be addressing the herniated nucleus pulposus, an issue that causes mild to severe pain on your back and neck. So, Professor, can you explain what this is and the causes of it?
Okay, first of all, I'll like to share with the audience what is the intervertebral disc. Some of the audiences may know. Basically, the intervertebral disc is a structure located between the bones of the spine or the vertebrae of the spine. So the disc has several functions. First of all, it functions as a shock absorber. Second, it provides flexibility for the patients to move, to bend, to twist their back. So if you look at the microstructure of the intervertebral disc, it is not homogeneous. What I mean is that it is actually comprised of two main structures. The inner structure is what we call the nucleus pulposus, which is surrounded by a ring-like annulus fibrosis. So the nucleus pulposus in the normal state is filled with water. And water is the one that provides the buoyancy, the shock-absorbing properties. The outer annular ring-like annulus fibrosis gives it the turgidity or rigidity, as well as it helps to contain the nucleus in the right place. So as we age, as injury happens to the disc starts to break down. So one of the things that happen during this breakdown process is there is a tear of the disc called the annular tear, the tear in the outer annulus fibrosis. This allows the material inside the disc, the nucleus, to protrude out and irritate the nerve. The degree of irritation varies depending on the amount of disc protrusion. Sometimes it is a mild, we call it a mild disc bulge. The patient just presents with back pain and minimal leg symptoms. Sometimes the protrusion is much more severe. The patient then will complain of more significant leg symptoms, including pain, pins and needles, numbness, or even loss of strength. And in the most severe or most profound case, the disc protrusion may be so large that the patient has loss of bladder or bowel control.
Okay. So you had mentioned here that as we age, this can happen. So are you saying that this happens to more of the old age, or do the younger ones also, or may the younger ones get HNP as well?
Okay, first of all, I would like to emphasize aging doesn't start from a certain age. Aging starts the moment we are around in existence.
Right. Okay.
Because it's a wear and tear process, But significant aging, of course, happens when you're much older. So, coming to this condition of a prolapse or herniated intervertebral disc, it is most commonly seen between the age of 30 to 50.
Okay.
Okay. So, what it means is that you need some time for the wear and tear or aging process to develop into clinically significant problem. Why is intervertebral disc prolapse or herniation less common in patients more than 50? Less common doesn't mean there are no cases, just that there are less. It's because in, for example, a very old patient like age 70 or 80, the disc is often very dehydrated. And if it's very dehydrated, it is probably harder or more difficult for the disc to protrude out to irritate the nerve.
Okay.
So in a much older age group, the nerve compression comes not so much from the disc, but from other surrounding structures, namely the ligament, the facet joint, as well as a misalignment of the bone. Right. So the endpoint is the same to a layman. I mean, the nerves get compressed. It's just that in a much older population, the compression source comes from structures other than the disc. Whereas for the younger to middle age, the compression source comes more from the disc, from the intervertebral disc prolapse or herniation.
Right. Okay. Thank you for the clarification, doctor. Now, what are the symptoms involved? Is there any particular or major symptoms before a patient should come and visit you?
Yes. If the patient has any neurological or nerve symptoms radiating down the leg, I think this is not a good sign. The patient has to seek medical attention as soon as possible. So what are the type of neurological symptoms? The pain radiating down from the butt or the glute, down the thigh, the calf, or the foot. It may not be the entire extent of the leg. It may just be the glute pain or the thigh pain, but that is sufficient enough to seek medical attention. Other symptoms that may raise a signal, alarm to come and see a doctor will be pins and needles over various parts of the leg, loss of feeling or loss of sensation, and some gait problems due to weakness. Suddenly, symptoms over both legs are more significant than over one leg. Symptoms associated with difficulty sleeping at night also warrant more urgent attention. Okay. Of course, we should not wait till bladder and bowel disturbances, loss of bladder and bowel control before medical attention is sought. That is, I think, too late. So there are early warning signs, as I mentioned earlier, pain, pins and needles, numbness, all this should ring an alarm to seek medical attention sooner rather than later.
Okay. Okay, so would the patient come and expect an X-ray or an MRI? What are the expectations of a patient when they come to seek medical attention?
Okay, most of the patients that we see have a few main concerns. One is the condition serious? Okay. Number two, whether the condition may lead to loss of mobility of the extremity. I'll put it shortly, whether will I get paralyzed? This is something that patient is always concerned. And third question they usually ask is, will I need surgery? Either now or eventually. And fourth is, after you have investigated me, what are things you can offer me in order to get me back into where I was before?
So you would be speaking, discussing, and investigating on the patient's condition and speaking to them about it and the options they have. So does the condition require surgery, or at what point would you say the condition requires surgery, or what are the signs to indicate the aggravation of the condition to warrant surgical intervention?
Okay, this is we are coming to surgical indications. Okay, there are several surgical indications. One is, of course, bladder and bowel incontinence or loss of control. This is the absolute indication for surgery. In fact, such scenarios should mandate surgery within 48 hours from the time of onset of bladder and bowel disturbance, because if not, patient may have permanent loss of bladder and bowel function.
Okay.
So fortunately, we see very, very rare instances of such a situation. Okay, the other absolute indications will be a loss of motor power, commonly foot drop from a large L4-5 herniated disc, leading to dysfunction of the L5 nerve root. So they are unable to walk on their heels, they have balancing issues. So this is another absolute indication for surgery. Okay, so the other indications are we call relative indications. Relative means you should consider surgery, but it's not absolutely mandatory that you need to do as soon as possible. And what are they? For example, a failure of conservative treatment, meaning you put patient through a trial of medications, physical therapy, acupuncture, lifestyle changes, and they don't seem to improve and the quality of life is affected. They cannot perform well at work, productivity is affected, they cannot take part in any recreational activities. So this is what we call relative indication. They are not responding to conservative treatment. That's number one. Number two, they are worsening despite conservative treatment. Okay, they are worsening despite conservative, and you may have to discuss with them the role of surgery. And I think this basically, we group them into absolute as well as relative conditions. And maybe third, the patient has no major deterioration, or maybe even there's a slight improvement, but that is not sufficient enough for them to resume the usual activities of daily living. They want to improve further. Right. So they have met a headwind, they have met a plateau in improvement, they are unable to get back to where they are before. And I think in such instances, you probably have to discuss the role of surgery. But there is some procedure in between conservative and surgery, and that is epidural steroid injections, or to put it broadly, spinal injections. So spinal injections can be offered as, we call it, a stopgap measure. So for cases that don't seem severe enough to need surgery, but yet they are not responding adequately well to conservative treatment. Right. So spinal injections may include epidural steroid injections to the nerve that is being compressed. We call it epidural steroids. Americans call it nerve blocks. The idea is to reduce the inflammation of the nerve in a more substantial, in a more rapid fashion, so that the patient can improve in their mobility, in their function much quicker. Or sometimes after doing a block, the physiotherapist may find it easier to handle or manage the patients. Because if the nerve is very, very irritable, often the physiotherapists find a big challenge to improve the patients, because everything gets seized up, everything is locked up. So with a block, maybe you can actually improve the patient further. But only thing is, the caveat is that they may not last that long. So we have to emphasize or communicate to the patients that such procedure may not be long-lasting, but it may tie you through. Hopefully the nerve can recover on its own with other treatment, for example, medications, physical therapy, and sometimes in some countries, acupuncture may also play a role.
Right.
Okay, if the disc prolapse is not too large, sometimes we can, at the same setting, apart from doing a nerve block or epidural steroid injection, we can do a procedure called a percutaneous nucleoplasty. So what it means is that we put a needle into the disc and apply radio frequency energy. Basically, is to ablate or reduce the bulge or protrusion of the disc so that there is actually less nerve irritation. But the amount of reduction of the disc volume we get is actually quite minimal. So it is only limited for cases where the disc protrusion is contained or is not too large. Such cases then may be amenable to a nucleoplastic procedure. But if it's for sequestrated or migrated disc or grossly extruded disc, so such cases will not be suitable for nucleoplasty. And if the patient fails conservative treatment, you may have to do the conventional discectomy procedure, which we will come to later. There are how you do a discectomy, which means removal of disc. You can either do a traditional open way or microscopic or keyhole, etc. We can come to that later as another part of the discussion.
Sure. So, doctor, how is it a long-term or short-term effect of the epidural injection? And how many times is a patient allowed to do it in their lifespan? Throughout
That's
their
an excellent question. Yeah. The epidural steroid injections is meant as a short to medium term procedure. But sometimes, with adjunctive treatment coming into play after you have performed the epidural steroid injection, the overall relief can be long term.
Right.
Because if we bring down the nerve inflammation to a substantial manner, other treatment can kick in. The effects will be long lasting. So basically, it is not a standalone treatment. We always emphasize to patients, it's a multidisciplinary approach.
Okay. And
By itself, it is not long lasting, but if you combine with other treatment, it can be long lasting.
And this would depend also on how the individual bodies react.
Correct.
With it.
Exactly. There's also another role of epidural steroid injections, which sometimes patients may not, or laymen may not understand. Is although we emphasize a lot on the therapeutic role of the injection, there's also an important diagnostic role. What I mean by diagnostic role is that when we do an investigation, for example, MRI, it only tells you that, at this level you have a disc protrusion, at this level you have a nerve being compressed, but it does not definitely or tell you that whether your pain definitely comes from that level.
Right.
Because we have a lot of incidental findings sometimes, which means that there is a disc bulge or disc protrusion and there's some contact with the nerve, but the patient's pain doesn't come from there. So the role of the epidural steroids, one of the role is a diagnostic role. What it means is that if the patient has good relief with this procedure, then we are very sure that the pain comes from there or the symptoms come from there. And even if this procedure is short or medium acting and if the patient needs a definitive discectomy or surgery later on, then we are pretty confident that we can actually alleviate the symptoms for the patient. So that is a role of epidural. Another role of epidural steroid injection, a diagnostic role, a confirmatory role that the source of the symptoms comes from that disc or comes from that nerve compression at that level.
Okay. And would this hurt? Would this injection hurt? Would there be some downtime after getting this injection?
Okay, this injection is done under sedation.
Okay.
Sedation means the anesthesiologist will be involved. They will administer various medications. It can be midazolam, it can be propofol or fentanyl. It's basically just to make the patient sedated, but they're not under full general anesthesia. Apart from that, we will apply some local anesthesia to the area that we want to inject the spine. So that we call it a double approach to actually reduce the pain or suffering of the patient during the procedure. It is important for the procedure not to be done under general anesthesia because we need the patient's feedback during the procedure.
Right.
So if it's done under general anesthesia, there's no feedback. So if there's no feedback, there is a slightly increased chance our needle will injure the nerve during the procedure.
Okay.
Of course, during the procedure, we also have image guidance. We use a mobile X-ray to guide the position of the needle to the area that we think the nerve resides or the area that we think the disc has prolapsed to irritate the nerve. But we still need the feedback of the patient to ensure it's another level of safety check to make sure that we are not too close to the nerve. As far as the downtime, this is usually done at a day procedure, which means the patient can be discharged on the same day.
Right.
And medical leave will usually range from 1 to 2 or 3 days. Is at most maybe a week, 5-6 days. So it depends on the nature of patient's work. So basically, the downtime is very minimal.
Okay. Okay, so say if the patient has to have a surgery done, what would the surgery entail? Maybe you can give us a brief explanation of the procedure involved there.
Sure. If the patient has failed conservative treatment or whatever other reasons, frank neurological deficits, foot drop, they need surgery. So first of all, we have to decide with the patient what is the best or most appropriate surgery. In order to come to that decision, we have to ask the patient where is the source of the pain or the symptoms that is most affecting the patient. Okay, most of the time in the prolapsed intervertebral disc, the most severe symptoms are actually from the butt and below. The patient usually doesn't complain of so much low back pain.
Right.
So in such cases, we will usually send the patient for an X-ray, we call a dynamic X-ray, which will try to show us that the level of surgical interest is stable. which means there's no, put it in a layman term, there's no instability, no frank misalignment of the spine at the area of the disc prolapse. Now, if there's no frank misalignment, then the patient is suitable for a keyhole surgery. Nowadays, we do not do, as far as I'm concerned, I do not do any open discectomy or open surgery to remove a disc. I do a keyhole surgery. I use a combination of tubular retractors, tubes of varying diameters, as well as a microscope to do the surgery. What we call a micro endoscopic discectomy, using a microscope and endoscope. So we use two sets of minimally invasive equipment to help with the surgery. Now, in a rarer group of patients that have a frank misalignment, maybe usually these are the older group of patients, a condition called spondylolisthesis. So they have misalignment, they have a prolapse disc, then, and also they may have a significant low back pain. So then we have to discuss the subject further as to whether at the time of discectomy, at the time of removal of the disc to decompress or free up the nerve, should we at the same time also do an instrumentation of fusion, means stabilizing the unstable segment? So that will entail a more involved procedure, slightly more major procedure. So it is like a joint decision. Some patients, despite having some misalignment, they feel that the symptoms are still more the leg and they're not so keen to have metal implants inserted. They may still opt for just a keyhole surgery. And after the surgery is done, the wound is healed, they go back to physiotherapy, get their core muscles strengthened. And hopefully with that, their instability doesn't get worse. And maybe they don't need further stabilization surgery down the line.
Right.
So as long as the misalignment, I think, is not too large, as long as the patient understands what is in store for them, as long as the symptoms are more the leg rather than the back, I think it is not unreasonable nowadays to just do a keyhole, because a keyhole surgery, the beauty about keyhole surgery, it doesn't destroy, it doesn't damage normal structures in the spine. Because if you damage normal structures in the spine, for example, in open surgery, then you tend to destabilize, you tend to make the area more unstable, which means the misalignment may get worse in future.
Right. Okay, so with this surgery, how long would a patient expect to be hospitalized for?
With a keyhole surgery, generally in our hands, the patients get hospitalized for about the median stay, which means most of the time they'll stay is about 2 nights. We have patients that stay for 1 night, and we have occasionally few patients stay for 3 nights. Depending on how comfortable they are with going home. But most of the time, they'll stay for about 2 nights.
Okay, and for those patients that come from Indonesia and they have to plan their traveling schedule, would they be looking to travel back to Indonesia soon, or do they need a bit of time longer in Singapore, as in having to come back for another checkup with to get approved?
Correct. That's a good question. So usually we tell them they need to cater for a keyhole surgery at least about a week in stay in Singapore. So the week includes a pre-operative or pre-surgery checkup and consent taking, explanation of risks and benefits, and actual stay in a hospital, as well as post-discharge follow-up. So probably they'll come 2 days, maybe 2 days before the surgery, and they'll stay 2 to 3 days in the hospital. And they will get reviewed back by me in the clinic 2 days after discharge and do a dressing change, answer any questions. So that will be about a week. But of course, they're welcome if they want to stay longer for various reasons. But I think at least they should consider a week stay. I think that.
Okay, and would they be planning to come back perhaps a month later for a checkup again?
Okay, that depends whether they have adequate facilities for someone at home to look at a wound, because a wound takes about 2 to 3 weeks to heal. So if they have no issues with getting expertise in managing the wound, then I will usually see them probably about 6 weeks' time. 6 weeks' time, 6 to 8 weeks. But if they have issue with the wound, then maybe I will ask them not to stay for 1 week, but maybe stay even longer. I mean, for the first go, maybe 10 to 14 days, because the wound takes about 2 to 3 weeks. So by 10 to 14 days, if the wound is fine, then it's less likely the wound is going to be a problem.
Okay.
Then I will see them again maybe about 6 weeks later.
Right. So this will all be communicated after the surgery, right?
That's right.
Professor?
Correct.
Okay. So I understand you mentioned that we need physiotherapy after the surgery, but what about the pre-op care? So in discussion about the pre-op and post-op care required, would they need downtime before the surgery? And do they need like an effective plan of rehabilitation before and after surgery, to make sure that their mobility is good?
Well, pre-op, if they're on blood thinners, for example, aspirin, they need to stop about at least 5 days before the surgery. Of course, with the permission of the doctor who prescribed the blood thinners. Other than that, of course, depending on the age, some of them, older patients, may need pre-surgery clearance with blood tests, maybe a ECG to check the heart. For the younger group of patients, they don't need any pre-surgery tests.
Right.
Now, as for post-op, once the wound has healed, meaning the dressing can be removed, the wound can be left exposed, then we will ask them to go back to the physiotherapist to start some kind of spinal stabilization exercises. Also, it depends, the type of physiotherapy the patient undergoes will a lot depend on the state of the patient, post-surgery. Sometimes when they come for surgery, the nerve is in a very bad shape. So, a lot of times the physiotherapists will have to do a little bit more slowly, will start more slowly. Sometimes they are completely well post-surgery, they don't have any more nerve irritation. Then, of course, the emphasis may be more on core strengthening and stuff like that. So
Right.
it's pretty much an a la carte approach depending on the state of the patient after the surgery. And which again that will also partly be dependent on the state of the patient just prior to surgery.
Okay. And is there anything the patient can do before surgery and after surgery on their own at home? Just for the
Okay,
better
before
of their...
surgery, I think if the patient is a smoker, he should make a conscientious effort to cut down smoking, because smoking speeds up the degeneration of the disc. So I mean that's for the state, the long-term health of the disc. So they should make an effort to cut it down. And of course, this cutting down will have to be continued post-surgery. The other thing the patient should do, of course, is to kind of avoid a state of prolonged recumbency. Well, what I mean is that a patient should not be traveling too much long distances before the surgery. I give you an example. There was quite a few years ago. We did kind of a surgery, a keyhole surgery on a patient who just flew from Scandinavia. So he flew in, he had a surgery immediately, and the post-surgery, he was previous nerve symptoms were kind of resolved, but he had a new pain in the calf. So, cut a long story short, actually, he had a deep vein thrombosis.
Right.
He had a deep vein thrombosis in the calf. So that probably arose because of the long flight, from Scandinavia. So sometimes this may pose a diagnostic dilemma to the physician, because deep vein thrombosis will also present as calf pain, and prolapsed disc can also present leg pain. So the quality. So I remember the case, we kind of took down the history, we assessed the quality of the pain. We found that the new pain he had is kind of different from the usual pain,
Right.
So that arose the suspicion of deep vein thrombosis. So I think, to cut a long story short, I think in order to avoid a lot of these diagnostic challenges and dilemmas, a patient should try to avoid prolonged traveling
Yes.
just before the surgery, in order to minimize the deep vein thrombosis are happening and therefore causing diagnostic challenges to the physician.
I would like to ask you if you have any experiences from patient case surgeries that you would like to share, which may be beneficial for our viewers to listen to.
Yeah, I have a case example. I have a case history of a patient. I think that she presented with a bladder issues. And actually, this patient is from Indonesia, from West Papua.
Okay.
So that was quite a few years ago. I vividly remember. So She came in with a urine catheter. She has severe back pain and sciatica and urine catheter. She saw a local doctor, and local doctor said it's due to urine infection and back pain. So both problems.
Right.
So basically, she had a large, extremely large prolapse disc causing a quadra equina syndrome. So that therefore led to her inability to control her bladder.
Right.
So I remember we went in on the same night to do a decompression. So when we do such cases of quadra equina syndrome and bladder incontinence, I elected to do an open procedure rather than keyhole because we don't have time to lose. We don't have a second chance.
Okay.
Okay, so we did an open surgery and really did a thorough decompression. And actually, she took a while to recover regards to bladder control. After that, I referred to urologist. She took about six to 9 months, eventually regaining her bladder function. But
Okay.
to be fair, this is a kind of lucky case because she waited a week before she flew to Singapore. If she's much older, sometimes the bladder function may not recover at all.
Yeah. Basically, when they have any symptoms, when patients have symptoms, it is good to get medical attention as soon as possible.
That's right. If it's something out of the ordinary, I think they should raise a red flag to come and see us. When this pain is something not the usual pain they have. Sometimes this prolapse this has been around for a long time. Patient has recurrent attacks. Well, if the symptoms are similar, exactly the same, maybe they can wait and see. But if the symptoms are a little bit different, maybe the quality of the pain, the intensity, the distribution of the symptoms are different. I think it's just better to seek attention, rather than trying to be your own detective and trying to monitor yourself.
Yeah. So one last question with regards to being our own detectives, Professor. Some local communities, they like to go and do the traditional massage, or in Indonesia, we know it as urut. And they think that that may help ease the pain. So with a back issue, would you recommend they can start off with doing this, or they should not touch their back at all?
Well, first of all, the traditional healer will not have the adequate knowledge of what is happening in the spine.
Yes.
So I think if the patients have access to reasonably good medical facilities, for example, in big cities, Indonesia, Surabaya, Jakarta, Medan, I don't see a reason why they should go to a traditional healer first. Because sometimes they may be counterproductive. They may cause iatrogenic injuries because they're not sure what is inside the spine.
Yes.
In older patients, they may even cause iatrogenic fractures. I've seen one case, a lady who had a traditional massage in Thailand, and she ended up with the spinal process fractures.
Okay.
So I think a medical attention is necessary. Let the doctor assess, take a history, do a physical check, do the relevant imaging investigations. At least we know the diagnosis, and then we can give proper advice. And if you need to do soft massage, I think a soft tissue release by the physiotherapists is probably more professional and safer than a massage done by a traditional healer.
Okay.
Because the physiotherapists can use other methods to help the patient. Sometimes it may be traction, it may be interferential, ultrasound, etc. There are more modalities at their disposal compared to a hard massage from a traditional healer.
Okay.
So in summary, I do not advise patients to go to a massage by a traditional healer. They should go and seek a proper medical consult, get the diagnosis confirmed. And if the diagnosis is not too severe, I think a trial of medications, physiotherapy, and sometimes acupuncture will be beneficial. And intermediate cases, a nerve block, epidural steroid, or nucleoplasty may be attempted.
Right.
Yes, surgery is usually reserved for the recalcitrant cases, or in some cases of frank neurological deficits or bladder bowel incontinence. Then urgent surgery will need to be done.
Okay. Well, this is great advice, Professor. Thank you so
Thank you.
much for your time.
My pleasure.
For our viewers, if you're interested in speaking with Professor Hee Hwan Tak, You can either go online at www.p-ortho.com or call +65 67370680 or send a WhatsApp to +65 9771 8964 to schedule an appointment. If you're planning to get your surgery in Singapore and live in Jakarta, you can start your physiotherapy at Physioactive Singapore and continue your rehabilitation program in Physioactive Indonesia. On behalf of our entire team at Physioactive Indonesia, we want to thank you for tuning in, and we look forward to bringing you more top quality content from Singapore's leading surgeons. Thank you.